Good evening to everyone and welcome to today's session. I hope that in our last journey in pharmacology, we had a review of pharmacokinetics, pharmacodynamics, the loading dose, maintenance dose, T-half, volume of distribution, bioavailability, etc. we have reviewed. We welcome our online students across the country, all the way Priyanka from Jodhpur to Subbalakshmi in Madurai. We have a opportunity for the students to sit at the comfort of the home and attend a MDS entrance coaching from the teachers across the country, reaching their home every day evening 5 to 8 p.m. Can the online students punch whether their voice is loud and clear, doctor? Can the online students punch? Very good. Please punch whether the voice is loud and clear. Any echo or any issue, please do be interactive because I can very much see you all. Now, doctor, NSAIDs. Why a common man goes to a dentist? The pain in the tooth, the pain in the ear, and the pain of the music of a tough spouse giving the routine chores of the market. Very difficult to bear. So, people go for the relief of the pain is what you need to remember. Now, the question is, which NSAID is a propionic acid derivative? So, you should be quite sure on what is the classification of the non-steroidal anti-inflammatory drugs. Some of them are both painkillers and they are also anti-inflammatory. Both the actions will be there. Salicylates, pyrozoline derivatives like phenylbutazone, indole derivatives like indomethacin, propionic acid derivatives like ibuprofen, anthralinic acid derivatives like mefenamic acid, aryl acetic acid derivative like diclofenac, piroxicam, nimesulide, ketorolac. These are the classical names you need to remember, where they have both pain killing ability and also anti-inflammatory activity. You have another class of drugs which are only analgesic, but they don't have any anti-inflammatory activity. What are they? Paracetamol. Lot of people don't know that acetaminophen and paracetamol are same. Acetaminophen is what Americans call it. Paracetamol is what Britishers call it. Crocin is what medical shop CNU calls it. In India, who is the major determinant of what to be taken? A medical shop seller, left and right will keep giving. People will come, I am having cold, give me something. And the medical shop guy will give. So, for a medical shop seller in India, it is Crocin, which is paracetamol for Britishers, which is acetaminophen for the Americans. All of them are same, that is paracetamol. Does paracetamol has any anti-inflammatory action? No. Only it has analgesic. Analgesic means pain relieving action. Similarly, metamizole is another drug which is also analgesic but a poor anti-inflammatory action. So, I am very happy to see Dr. Vidya, Dr. Priyanka and many more online. Now, doctor, how do these NSAIDs basically act? Our cell membrane releases from the membrane lipids arachidonic acid. Arachidonic acid is acted upon by lipoxygenase so that leukotrienes form, or it is acted upon by cyclooxygenase, then prostaglandins basically form. So, for prostaglandins and leukotrienes, what is the common precursor? Arachidonic acid. Arachidonic acid comes from the membranes, that is phospholipase C and A2 will break down the membrane lipids into arachidonic acid is what you have to fundamentally remember, doctor. Now, if you take most of the NSAIDs that we commonly use in the clinical practice, they basically inhibit cyclooxygenase. Cyclooxygenase will convert arachidonic acid into prostaglandins. Lipoxygenase converts it into leukotrienes is what need to be remembered. Now, because of this inhibition of cyclooxygenase, we get a diminished prostaglandin production, and it is the prostaglandins which are responsible for all that pyrexia. Why will prostaglandins will be responsible for pyrexia? Because prostaglandins will tell hypothalamus, see hypothalamus, you are thinking that this man is in a normal temperature. No, hypothalamus, he is in a very high temperature, like a desert he is in. The prostaglandins will go and tell hypothalamus. Hypothalamus is our temperature controlling center in the brain. Suddenly hypothalamus get fooled when prostaglandins tell like that, and it will set the temperature set point high, and we get pyrexia. So how to bring down pyrexia? You diminish prostaglandin production so that a wrong information will not be told to our hypothalamus, and it won't mistaken that we are in a desert. It won't mistaken that we are in Jaipur. Suppose you got high grade fever in Shimla, because of this misinformation to hypothalamus, body will think that it is in Jaipur in a desert, and we get pyrexia. So diminished prostaglandins are essential for the antipyretic action, analgesic action, and anti-inflammatory action is what need to be remembered. So what is the difference between aspirin, ibuprofen on one hand, and acetaminophen, which is called paracetamol, in the other hand? Aspirin or ibuprofen are the NSAIDs which have both anti-inflammatory and also analgesic and antipyretic action, whereas paracetamol or acetaminophen has only analgesic and antipyretic but no anti-inflammatory action. That's what you have to fundamentally understand. What is most important thing about acetaminophen is my question to all of you. How is it metabolized in our body? Can we take kilos and kilos of acetaminophen? We cannot take. Acetaminophen after consumption will undergo conjugation and forms a sulfate moiety, which is basically non-toxic. Acetaminophen is also metabolized by the P450 system. You remember what are P450 inducers and inhibitors we discussed in the last class on Sunday? Don't forget, because that is what they are going to ask in exam. So when P450 acts on acetaminophen, it is converted into a substance called N-acetyl P-benzoquinone imine, NAPQ, and that is also toxic. Then this NAPQ is converted into cysteine and mercaptopurine, and for that you require some reducing equals, for that you require some sulfur molecule, because glutathione provides the, thio means what? Sulfur. Glutathione provides that sulfur moiety and converts this N-acetyl P-benzoquinone imine into cysteine and mercaptopurinic acid, so that it becomes non-toxic. But this glutathione is a tripeptide. For the regeneration of the glutathione basically forms from, is in two forms, reduced form and oxidized form. You constantly require NADH. NADH is provided by pentose phosphate pathway. If you consume lot of paracetamol, what will happen? Lot of paracetamol will form lot of NAPQ. Lot of NAPQ require lot of glutathione. lot of glutathione required, lot of NADH. Lot of NADH comes from, unless pentose phosphate pathway is abundantly available. At one point of time, pentose phosphate pathway is saturated. It can't anymore provide reducing equivalents. So glutathione is no more available. Then the toxic metabolite of the acetaminophen remains, and that lead to liver toxicity and liver failure. That's the reason, doctor, acetaminophen is a safe drug, paracetamol. But just because patient says, no, my temperature is not coming down, every half an hour I am checking, then if you keep giving every half an hour one 650 milligram tablet, patient will end up in a liver failure. So you need to be careful while administering paracetamol. Now doctor, which drug is called selective COX-2 inhibitor is an important question. Swati is online. Swati is saying that the broadcast is getting stuck up. Can you please help Swati? Maybe she need to refresh her browser, or she need to check her internet speed. I hope that is not the problem for Vidya or Priyanka or anybody else who are online. Okay. Anyway, support, please help Swati. She need to refresh her browser. Now doctor, meloxicam is the traditional NSAID which is called selective COX-2 inhibitor basically. Now comes doctor a very important question. What is the funda of COX-2 and COX-1? Let's be very sure. COX-1 is a constitutive enzyme, doctor. Stomach, kidney, intestine, platelets, endothelium. In all these places, COX-1 is the isozyme of the cyclooxygenase which will be present. It is constitutive. That is, fundamentally, your stomach require a good amount of blood supply. Why? If blood supply to the gastric mucosa is sufficient, then the mucosa will form adequately so that acid will not injure the stomach. For that, what do you require? Prostaglandin. That prostaglandin is produced by COX-1. Suppose if you happen to give a non-selective COX inhibitor, cyclooxygenase inhibitor, it will go and inhibit the COX-1 in the stomach. Then what will happen? Your prostaglandin in the stomach diminishes, gastric mucosa blood supply diminishes, gastric mucosa will be inadequate, and you get the ulceration, peptic ulceration in the stomach. Okay, doctor. Then why are you giving a COX inhibitor, basically cyclooxygenase inhibitor? You want it to act on COX-1 or COX-2? For what purpose you are giving it? It has to work on COX-2. Because why COX-2 it is important? COX-2, cyclooxygenase 2, is present in our macrophages, inflammatory cells. It is present in our synovial cells. In all these places you are having cyclooxygenase type 2. And cyclooxygenase type 2 here also will produce prostaglandins. Since it produces prostaglandins by macrophages, it leads to inflammation. Because it produces prostaglandins by the synoviocytes, it leads to synovial inflammation. So you are giving a cyclooxygenase inhibitor basically to inhibit the prostaglandins in COX-2 produced locations, that is macrophages and synoviocytes. But the same cyclooxygenase inhibitor is going and inhibiting the COX-1, and it is in COX-1 locations. Do you want or you don't want prostaglandins? COX-1 locations. Normally COX-1 location where prostaglandin produced is helping stomach, so you want it. In kidney you want it, because the prostaglandin produced in the kidney by the COX-1 lead to vasodilation of the afferent arteriole, increases the blood flow to the kidney. Hence you require the COX-1 and prostaglandins in stomach, kidney, intestine, platelets and endothelium. You don't want COX-2 in macrophages and synoviocytes. You are giving a NSAID to mainly inhibit COX-2 to bring down inflammation. But unfortunately, if it is a non-selective inhibitor, it not only inhibits COX-2, it also inhibits COX-1, and you don't want COX-1 inhibition. So that is the reason whenever you are using a non-selective COX inhibitor, you have a hell lot of side effects on the stomach, on the kidney, on the intestine, platelets and endothelium. So then what did they think? Oh, this is very bad. We are using the COX-2 for a good purpose to bring down inflammation by inhibiting COX-2. This fellow is going and unnecessarily inhibiting COX-1. Let us find out only such NSAIDs which are only COX-2 inhibitors without affecting COX-1. Is it good or bad? It is good. That is how came the discovery of COX-2 inhibitors, is what you need to basically remember. That's right. So doctor, what is very important is, let's go back. Meloxicam. So every NSAID, whenever you look at it, what will you check? Is this a COX-2 inhibitor or is this a COX-1 inhibitor? That is what you will check. Meloxicam selectively inhibits the COX-2 compared to that of COX-1. So good or bad? Good. Piroxicam, it is a non-selective COX inhibitor. Good or bad? Bad. Ibuprofen, non-selective COX-2, COX-1 inhibitor, but still we use it because it is a wonderful anti-inflammatory agent, ibuprofen. But if you take ibuprofen, a lot of times you have gastric irritation. For pain, for dysmenorrhea or any menstrual pain, when ibuprofen is used, for a lot of reasons when we use ibuprofen, gastric irritation is very severe. Ketorolac. Ketorolac is another example of non-selective COX inhibitor. That is what you have to basically understand, doctor. Then what are those selective COX inhibitors? Is a very, very important question. Nimesulide, nebumetone, meloxicam are the three musical words you need to remember when you are going for a MDS entrance preparation. They are all called selective COX-2 inhibitors is what need to be remembered. Celecoxib, rofecoxib, they are also selective COX-2 compared to that of the COX-1 is what I want to conclude for all of you. Now doctor, ketorolac, what is the true statement about ketorolac? It is an effective analgesic, especially for mild to moderate post-operative dental pain we use ketorolac. But ketorolac is a non-steroidal anti-inflammatory drug. There are three painkillers, doctor. Steroidal anti-inflammatory, non-steroidal anti-inflammatory. Similarly, you have painkillers like opioid analgesics, etc. Is ketorolac is opioid or is it morphine? No, it is not. Similarly, is it administered only by intravenous? No. So we need to know ketorolac can be given IM, ketorolac can be given IV. Both the ways you can be able to administer. And ibuprofen can be given both IV and also you can also give orally. So where do you give ketorolac? For a mild to moderate post-operative dental pain, you can give ketorolac in the form of a injectable. Now doctor, which NSAIDs undergo a lot of enterohepatic circulation is my question to all of you. Basically, piroxicam, it's a very unique property. Whatever you take after oral administration, it becomes absorbed, undergoes enterohepatic recirculation, and because of this enterohepatic recirculation, see doctor, piroxicam. Normally a drug, what happens? Once it enters blood, if it enters liver, if it enters bile, it once more enters intestine, and through intestine it goes into feces. But if it has enterohepatic circulation, what will it happen? When it enters through bile into the gut, instead of going into feces, it will be recirculated back to the liver. What connects the intestine to the liver? We have a portal venous system. Remember, intestine connected to liver by portal vein. From the liver, in the liver, all this blood will form hepatic sinusoids. They all will merge. They form hepatic vein. Hepatic vein drains into IVC, inferior vena cava. Inferior vena cava drains into heart. So this is how the circulation is. Summarize: intestines, portal circulation to the liver, liver, hepatic sinusoids to hepatic vein, goes into IVC, which goes into heart. That is the story. So what is enterohepatic circulation? From the intestine through the portal system, it is reabsorbed back into, goes back into liver. Whereas other drugs, what happens? When they go into blood, they go into liver. When they go into liver, they go into bile. From bile, they go into intestine, and through intestine, they are excreted into feces. So that doesn't happen for piroxicam. Hence, piroxicam has got a long half-life, is what you have to basically remember. Now, what are the other drugs which also are known to have enterohepatic recycling? Now you understood the funda. If any drug has an enterohepatic recycling among NSAIDs, it will have a long half-life. That's the point. Tenoxicam, naproxen, indomethacin, tolfenamic acid, and daracoxib, they all basically exhibit the enterohepatic recycling, is what you have to basically remember. Now piroxicam. Piroxicam, where do we use, doctor? Any inflammatory state, rheumatoid arthritis, ankylosing spondylitis, their spine become fused like a bamboo stick. It is not that flexible like normal person's neck. Ankylosing spondylitis, gout, where high uric acid levels will lead to activation of macrophages and lead to inflammation involving the joints. Gout. Primary dysmenorrhea, the pain which occur at the time of menstruation, and post-operative pain. In all these scenarios, we use the piroxicam, is what need to be remembered. Now doctor, what is meant by sealing effect of NSAIDs? Simple. This one graph you need to remember. If you take morphine as a painkiller, let us plot pain relief on y-axis and the dosage on x-axis. As you keep increasing the dosage of the morphine, analgesic activity will be increasing. Whereas in the case of NSAIDs, if you increase the dosage till one point, analgesic effect also will increase, but after that it remains plateaued. That's called sealing effect of analgesics. Analgesic sealing effect of NSAIDs is what you need to basically remember. With which NSAID you see less amount of GI bleeding is a very important question. COX-2, specific inhibitor if you use. Why? Because COX-1 is good COX. COX-2 is a bad COX. You want to kill the bad COX, which is COX-2. You don't want to affect the good COX, which is the COX-1, is what you have to basically remember. So tell me doctor, what are all the list of the agents which are basically called? Somebody please help Swati. She still is getting offline. Maybe I think a local internet issue. You need to have at least 1 Mbps line. Nowadays 1 Mbps has become a norm. Even on mobile phone you are getting higher speeds. Right doctor? So maybe Swati can call the helpline and take a help for a better transmission. So now doctor, Diclofenac, ibuprofen, ketoprofen, aspirin, naproxen, piroxicam, indomethacin, mefenamic acid. They are all non-selective. Don't remember. Better remember the smaller list. What is the smaller list? Meloxicam, but not piroxicam, is a selective. All coxips. Is there any coxip in this list? No. You have only coxips in this. All coxips and meloxicam are the selective NSAIDs which only selectively inhibit COX-2 but not affect the COX-1 is what need to be remembered. So rofecoxib, celecoxib, valdecoxib, they are all the selective COX-2 inhibitors is what need to be remembered. Meloxicam, nimesulide, diclofenac, etc. They are the newer forms of a novel COX-2 inhibitors. Now doctor, if there is a lot of gastric irritation produced by the NSAIDs, how do you want to treat that gastric irritation is an important question. Very simple. First of all, why there is a gastric irritation and why there is a development of an ulceration in the stomach whenever you are using NSAID? Because it is inhibiting COX-1. COX-1 normally produces prostaglandin in the stomach and that prostaglandin is increasing the blood flow to the mucosa of the stomach. Try to increase the blood flow to the mucosa of the stomach by administering a prostaglandin. You give the NSAID, but NSAID diminished prostaglandin. You also administer a prostaglandin. So which is that prostaglandin which we administer? Misoprostol. Cytotec, common brand. Cytotec is protect, right? So what does it basically contain? Misoprostol. Misoprostol is basically a prostaglandin which is often used in order to protect the gastric mucosa, because it being a prostaglandin will promote the blood flow to the gastric mucosa is the one which we basically administer. So let us look at the algorithm of the management of the NSAID induced ulcers, doctor. Best is stop NSAID, initiate a proton pump inhibitor. Proton pump inhibitors are, we'll come back to the anti-ulcerative agent. Agents is a different story. Sucralfate is that typically a layer forming syrup. You can use that. And always check whether there is any H. pylori, Helicobacter pylori growing. If it is positive, treat it. If it is negative, you can't help it. I mean, it is not responsible. Then if you can't discontinue NSAID, then what you need to do? Because if you stop NSAID, the inflammatory state is worsening. Just because gastric ulceration is there, if you stop NSAID, if the inflammatory state is worsening, you need to continue NSAID and you need to give some protection, and that protection is offered by the misoprostol, or you give such an NSAID which is a selective COX-2 inhibitor like meloxicam. That is the protocol. Okay, doctor? Am I going too fast? No, because you need to tell me how fast I should go. I generally go at least 5 to 6 times the speed in the regular classes. Oh, very good. I am happy to see around 8+ online viewers. Right. So you have any query that you are not comfortable with the speed, please do punch into the chat window. Now doctor, prostaglandins are of various varieties, E1, E2, F2 alpha, etc. Which series of prostaglandin is the misoprostol? Is a favorite question of the examiner. Prostaglandin E1 is the misoprostol which is used to treat the NSAID induced ulcers is what you need to basically remember. Now, what are the various agents which are proton pump inhibitors? How is acid produced? In the stomach, H+. What is acid in the stomach? HCl, hydrochloric acid. For that you require H plus ion, protons. They are basically exchanged against the potassium, so that against K plus, H plus is exchanged, and that H plus participates in HCl formation. That K plus H plus exchanger is called proton pump. When proton pump works, H plus is pumped, HCl forms. That's how the acid forms in the stomach. To decrease acid production in the stomach, you can use proton pump inhibitor. What are the drugs which are called? Omeprazole, lansoprazole, rabiprazole, pantoprazole. These are all basically called proton pump inhibitors, is what need to be basically remembered. Now doctor, which drug can you give safely in the management of peptic ulcers? Peptic ulcers. Acetaminophen. Why? Acetaminophen compared to ibuprofen, diclofenac or aspirin will not affect the stomach wala cox that much. Hence you can use it safely in the people who are having peptic ulcers. That is a very important point. Now what is the dosage of acetaminophen? 325 to 1000 milligrams. If you are giving rectally also paracetamol can be given, especially in pediatric population. 650 milligrams rectally. Generally the rule is don't give paracetamol such that the dosage exceeds 4000 milligrams in a day. Normally what is the common tablet we give, doctor? Dolo 650. Priya and Swati are asking, tell about proton pump inhibitors once more. Simple, doctor. Proton pumps, what is proton pump? Against K plus ion, potassium ion, H plus ion is pumped into the lumen of the stomach at the gastric epithelial cell. That H plus is what? H plus is proton. Proton is acid. A H plus donor is called acid. H plus acceptor is called base. That's what our intermediate chemistry teacher taught us, no? Plus 2 wala chemistry teacher, right? So this pump, if you inhibit, you make H plus non-available in the stomach for the acid formation, so that you can decrease the acid production in the stomach. So that is the purpose of giving a proton pump inhibitor, which include omeprazole, lansoprazole, rabiprazole and pantoprazole is what need to be remembered. Now doctor, normally what is the tablet? I think Priya is convinced about the proton pump inhibitors. Good. Now, what is the common brand? Dolo 650 milligrams wala tablet dete. Then we say to patient, you can take it 3 times daily, 8 hourly. 650 into 3 become kitna? Around 1950 milligrams. You can give up to 4000 milligrams. But if he is an alcoholic patient, your patient is Devdas, then you have to tell only maximum 3 times of this 650 mg you can be able to take, is what need to be basically remembered. Now doctor, regarding acetaminophen, if there is a chronic overdosage of the paracetamol, it can lead to hemolysis, methemoglobinemia, cyanosis, they are all the side effects. In the pediatric population, paracetamol can lead to renal tubular necrosis, hepatic necrosis, etc., etc. It also has analgesic, antipyretic, but no anti-inflammatory action, is what need to be remembered. Now one question comes. Patient tells, doctor, last time you gave me aspirin, but after taking aspirin I had that bronchospasm. Aspirin can induce bronchospasm. Why bronchospasm occur with aspirin? That also let us be very sure. Aspirin is inhibiting cyclooxygenase. You agree with me? Because it's an NSAID. For cyclooxygenase and lipoxygenase, who is the common mother? Phospholipids of the cell membrane, arachidonic acid. So when arachidonic acid cannot form prostaglandins because cyclooxygenase got inhibited, it will form more amount of leukotrienes because it becomes a substrate for the lipoxygenase. Because your aspirin is inhibiting only cyclooxygenase without inhibiting leukotriene production. So all the arachidonic acid instead of forming prostaglandins will be diverted towards formation of leukotrienes. So leukotrienes are strong bronchoconstrictors. Hence asthma get precipitated if you give aspirin. That's called aspirin sensitive asthma. For that matter, lot of NSAIDs are known to have a side effect of provoking the bronchospasm is what you have to basically understand. So patient told you, doctor, last time I had a asthmatic episode because of your aspirin. So for such a patient, can you give paracetamol? Paracetamol will not cause any cross reactivity to aspirin. That's what you need to basically understand. Now which drug has a poor anti-inflammatory action? Now you are confident of the answer. Paracetamol. Then which drug you can give safely in a patient of congestive heart failure? Once more, paracetamol. Because if you give aspirin, if you give ibuprofen, they have lot of side effects which will be bad for a patient of congestive heart failure. Now what are those side effects caused by them? If you give aspirin or ibuprofen or diclofenac sodium, they are all what? Cyclooxygenase inhibitors. They decrease prostaglandin production. Prostaglandins are important for what purpose in kidney? In kidney, prostaglandins stimulate afferent arteriole, increase the blood flow to the kidney. Right? If you happen to decrease prostaglandin production, afferent arteriolar production, dilatation doesn't occur, blood flow to the kidney diminishes. Already heart is in failure. It is already pumping very little blood that is going to kidney. On the top of it, you are also diminishing prostaglandins and further decreasing the blood flow to the kidney. Ultimately, the blood flow to the kidney critically decreases. Hence, they are unsafe in patient who is having congestive heart failure is what you need to remember. That problem doesn't exist with paracetamol is what you need to remember. What is meant by APC? Aspirin, phenacetin, caffeine. Originally they used, once upon a time, 1940s when people used to practice, 1950s, there are only 3 bottles available in the hospital. Penicillin bottle, chloroquine bottle, paracetamol bottle. You see that old movies, doctor will come seriously, he will see patient seriously, ultimately what will he write? ये दवा दे दो उनको पिलाओ और उनका बीमारी कम हो जाएगा. What is that दवा? Paracetamol, he will give and go. 1950s का movies है ना, नागेश्वर राव, एन.टी. रामाराव और you see राज कपूर movies. बहुत बुखार है डॉक्टर साहब, कुछ ना कुछ करो. Oh, definitely, doctor comes seriously, one guy will be bringing the box. Ultimately, he will check everything and what will he give? Acetaminophen, phenacetin or caffeine. APC was a famous combination. But now medicine has evolved to leaps and bounds. We are managing patients in a comatose state for years together, right? On ventilators. Now doctors, what is not true about aspirin? Why aspirin lead to analgesia? Not by going and affecting the CNS. Aspirin's anti-pain effect is due to its peripheral action by diminishing prostaglandin production peripherally, not by going and acting on the CNS. That is the point you need to appreciate. So summarize, doctor, how does aspirin act? Aspirin inhibits cyclooxygenase. So the arachidonic acid to prostaglandin G2H2 diminishes. Prostaglandin G2H2 is the precursor for thromboxane A2 formation. For the thromboxane A2 formation, you require thromboxane synthase, and thromboxane A2 production is important for the activation of the platelets and aggregation of the platelets. That's the point you need to appreciate. That's the reason if you give aspirin, what will happen? It affects the thromboxygenative production. If thromboxygenative is not there, platelets cannot aggregate. So platelets become deaggregated. If they aggregate, clot forms. If they don't aggregate, clot doesn't form. So hence, if you don't want clot to form, like somebody has coronary artery disease, somebody has a stroke tendency, somebody has an ischemic heart disease, you don't want the blood clot to form, you don't want platelets to aggregate, hence you give the aspirin. How will aspirin will do that? Aspirin inhibits cyclooxygenase, decreases prostaglandin G2H2, decreases thromboxygenative formation, decreases the clot formation, decreases the platelet activation, decreases the platelet activation. That is how aspirin is used for its clot forming preventing ability, is what you have to basically understand. Now, doctor, if you take platelets, if you take vasculature, blood vessels, what is the main difference? Platelets produce arachidonic acid, blood vessels also produce arachidonic acid, and the arachidonic acid in the produced by the platelets in turn will form prostaglandin GH. For that you require COX-1. Prostaglandin GH forms thromboxane. Hence, if aspirin is given, COX-1 is inhibited and hence thromboxane formation diminishes, and that lead to antithrombotic action is what need to be remembered. Now, doctor, a very important question comes. The pain in human beings is of various kinds. Pain arising from viscera. Suppose you have appendicitis, you have peritonitis, that is called visceral pain. The pain that arises from the integument, skin, because of that sensory nerves innervating our skin, that is called integumental pain, peripheral pain. Is the salicylates more effective for treating a visceral pain or an integumental pain? More often they are useful for a low intensity type of integumental structure pain like your headache. If you are having appendicitis and you take aspirin, that won't relieve it much. That's the point. And the main action of the salicylates is by virtue of their peripheral action, not central action. Now let us talk about salicylate poisoning. All the critical features of salicylate poisoning, you need to be very clear, doctor. Most important side effect, don't forget, tinnitus, a ringing sensation in the ear. It leads to lethargy, excitability, nausea, vomiting, and a very important effect of salicylates is, it will go to the respiratory center, stimulate the respiratory center, and the person starts hyperventilating. So hyperventilation is an important side effect of salicylate intoxication. A very common question asked in the exam is, when you ventilate, what kind of acid-base disturbance will you develop? You know acidosis, alkalosis, two kinds of acid-base disturbances. Whenever you hyperventilate, you are expiring the carbon dioxide. When you expire a lot of carbon dioxide, there is no carbon dioxide available in the body. For what? Carbon dioxide combines with water to form carbonic acid. Carbonic acid breaks down into bicarbonate and H plus ion, and that releases the H plus ion. Right? For the acid formation in the blood, you require carbon dioxide. Carbon dioxide plus water gives carbonic acid that breaks down and releases H plus, and H plus contributes to acidic pH of the blood. If you hyperventilate and you exhale all that CO2, you don't have CO2 available for forming acid in the body. If the acid is not formed in the body, what will happen? alkalosis will occur, and that's called respiratory alkalosis. Summarize, doctor. Hyperventilation leading to decreased CO2 leading to decreased acid production leading to alkalosis is called respiratory alkalosis. Whereas you take salicylate, in salicylate due to hyperventilation it leads to respiratory alkalosis. But salicylate itself is an acid. Acetyl salicylic acid is the name of the aspirin. Because you took it in a toxic dosages, it leads to acidosis. Because it itself is an acid. Hence it also leads to metabolic acidosis. So both metabolic acidosis, respiratory alkalosis, both of them can occur whenever there is a salicylate intoxication, is what you need to understand. Another common confusing question asked about salicylate toxic poisoning. If you take salicylate, it is used as what? Antipyretic. If you take excess salicylate, what do you expect person to develop? All his heat should go away and his temperature should fall and he should develop hypothermia. No. In salicylate intoxication, temperature rises. Patient goes into hyperthermia. Why? Why is the question. Salicylates, when they are taken in a toxic proportion, will go to the mitochondria. They do the uncoupling of the electron transport chain. Because of that uncoupling, what happens? Normally, the energy produced from the ATPs, the energy produced by the electron transport is supposed to convert into ATP formation. If you uncouple that, what will happen? The energy produced can't convert into ATP, it becomes released as heat, and hence temperature will increase. Hyperthermia, severe hyperthermia will occur if there is a salicylate intoxication. Summarize, doctor. What are all the side effects of salicylate intoxication? Hyperthermia, development of tinnitus, lethargy, hyperventilation leading to respiratory alkalosis and metabolic acidosis. These are all the important side effects is what need to be basically remembered. So when is aspirin contraindicated? Aspirin, a salicylate, has a lot of side effects and drug interactions. One of the favorite MCQ of the examiner is, what are all the drug interactions of the aspirin? You need to be very clear. Let's talk about it. Now, NSAIDs, not only aspirin, other NSAIDs also, they all will attenuate the effectiveness of ACE inhibitors. ACE inhibitors are enalapril, lisinopril, ramipril, all that which we use for treating hypertension, which we use in congestive heart failure. Their effects are attenuated, that is weakened by the NSAIDs. चलो, पहला हम ACE inhibitors किसके लिए इस्तेमाल करते उसके बारे में बात करेंगे. ACE inhibitor, what is ACE inhibitor? Angiotensin converting enzyme inhibitor. What is angiotensin converting enzyme? Which converts the angiotensin 1 into angiotensin 2. If you happen to inhibit it, then what are you decreasing? Formation of angiotensin 2. By doing that, what do you want to basically achieve? Normally angiotensin 2, what it will do? It lead to vasoconstriction. Vasoconstriction of the blood flow to the vessels going to the glomerulus, kidney. Right, doctor? So, if you happen to inhibit the formation of this angiotensin 2, right, you will cause vasodilatation vasodilatation and improve the blood flow to the kidney. Whereas if NSAIDs are used, NSAIDs, what will they do? They diminish prostaglandin production. Prostaglandins normally increase blood flow to the kidney, and that effect is prevented. So blood flow to the kidney is diminished by usage of NSAIDs. Normally ACE inhibitors are known to improve the blood flow to the kidney. So hence they have opposite effects to that of the ACE inhibitors. Hence they will attenuate the effectiveness of ACE inhibitors. That's what we need to basically remember. Then commonly in inflammatory state, what we do? We combine corticosteroids and NSAIDs. Steroids are anti-inflammatory. Non-steroidal anti-inflammatory agents like your aspirin is also anti-inflammatory. When you combine the two, both steroids promote ulcer formation in the stomach, NSAIDs will also. So together if you give, gastric ulceration become very severe. That's the point you need to appreciate. Then warfarin. What is basically warfarin? Warfarin is an anticoagulant, doctor. Okay. What is the story of warfarin? Why it is anticoagulant? How it is preventing the clot formation? Very simple. Warfarin is anti-vitamin K. K. Why do you need vitamin K? You require vitamin K in order to, it acts like a coenzyme, vitamin K, for a very important enzyme called gamma glutamyl carboxylase. And this gamma glutamyl carboxylase, what it will do? You have clotting factor, no? A inactive clotting factor is there. Clotting factor, when it is produced like an inactive one. On the clotting factor, you have a glutamate residue. That glutamate residue, unless it is carboxylated, clotting factor doesn't become an active clotting factor. Understand? A clotting factor in an inactive form is not in a carboxylated state. Only when it is carboxylated it becomes active clotting factor. For the carboxylation of the glutamyl residue on the clotting factor, you require a vitamin K gamma glutamyl carboxylase. The gamma glutamyl carboxylase enzyme is dependent on vitamin K. So the vitamin K is in a form called epoxide. That vitamin K epoxide becomes vitamin K quinol and basically donates a carboxyl group which is used by the gamma glutamyl carboxylase to carboxylate the glutamyl residue on the pre-clotting factor into an active clotting factor. If you give warfarin, it will inhibit this vitamin K epoxide converting into quinol. So that what will happen? Carbon dioxide cannot be supplied to the gamma glutamyl carboxylase. If that is not supplied, glutamyl residue is not more carboxylated. If it is not carboxylated, it can't become active. If it can't become active, it is inactive. If it is inactive, then it can't form a clot. That is how warfarin is used to prevent a clot. So if the clot doesn't form, what happens to us? We start bleeding. Right? Warfarin is a common anticoagulant we use. People who have a tendency to form their blood clot quickly, to thin their blood, to prevent the clot formation, we use the warfarin. Now doctor, a very important thing is, if you combine NSAID and warfarin, what is the effect of it? Basically warfarin is protein bound. It is bound to albumin. NSAID also want to bind with albumin. Albumin is in triangular love story with two heroes, one NSAID, one warfarin. It has to choose in whose neck it has to put garland. NSAID says, मेरे पास गाड़ी है, बंगला है, वो है, ये है. I am having higher affinity to you than this poor fellow called warfarin. Then immediately what will albumin will do? Oh please NSAID, you come, I will marry you, and it will kick off the warfarin. When the warfarin became more free form, its action increases, and that lead to unexpected toxicity. What is the toxicity of warfarin? It is an anticoagulant. It leads to bleeding. If it is toxic, more bleeding. That's the reason NSAIDs displace the warfarin from the protein binding site on the albumin and predispose to the development of the risk of warfarin induced bleeding is what you have to basically remember. So doctor, in summary, with anticoagulants, what is the effect of NSAID? It displaces and causes worsening of bleeding. Aspirin itself is bleeding promoting. Why? Aspirin inhibits thromboxane formation, diminishes thromboxane formation in platelets. Thromboxane aggregates platelets, so it deaggregates if thromboxane is not there. So already because of aspirin there is a anticoagulant, antiplatelet action. On the top, your clotting factor protection also is affected, hence bleeding become worsened. Lithium. Lithium is a common drug we use in mania depressive states. Lithium. NSAIDs inhibit the elimination of the lithium by the kidney. Normally lithium is eliminated by the kidney. If you use NSAID, lithium is never eliminated and lithium levels increase. Lithium lead to lithium intoxication if you use NSAIDs. Then antihypertensives. We have seen antihypertensives like ACE inhibitors. Their function is opposed by NSAIDs. So they will diminish the antihypertensive effects of ACE inhibitors. That's what you need to basically remember. Then another important group of drug, don't forget, this is a favorite MCQ in the entrance. What are all the drugs which show drug interaction because of their displacement from the protein binding whenever you use the warfarin? The list, whenever you use the aspirin. Warfarin, sulfonylurea hypoglycemic agents. In diabetes patients we use glibenclamide, glipizide, gliclamide, right? They are all called sulfonylurea class of diabetic drugs. They also want to be protein bound, but after the arrival of aspirin, albumin don't want to marry anybody, it only want to marry aspirin. So it will say goodbye to all the old boyfriends like warfarin, sulfonylurea, hypoglycemics and methotrexate. They all become displaced from the albumin and that intoxication will increase. So doctor, don't forget, ACE inhibitors, steroids, warfarin, sulfonylurea, methotrexate. What are the drug interactions? All the drug interactions of the warfarin you need to be very sure about. NSAIDs you need to be very sure of. Now doctor, there is one more important effect of aspirin. What is that? Spironolactone. What is this drug basically? Spironolactone is called mineralocorticoid antagonist. Just before we studied, no? Kidney produces renin. Renin causes angiotensin 1 formation from angiotensinogen. Angiotensin 1 by action of ACE, angiotensin converting enzyme, converts into angiotensin 2. Angiotensin 2 stimulates aldosterone. Aldosterone is called mineralocorticoid. Aldosterone goes and acts on the kidney and causes the retention of sodium and water. We use spironolactone for what purpose? Suppose if a guy has congestive heart failure, his heart is unable to pump blood sufficiently. When the blood pumped by the heart is less, blood going to kidney is less. When the blood going to the kidney is less, kidney will produce renin. Renin will lead to angiotensin, angiotensin will lead to aldosterone, aldosterone will lead to sodium water retention, right? And the sodium and water are retained in the body, right? That is what happens whenever we have congestive heart failure. But because of the retention of sodium and water, what happens? Person become edematous and puffy. Hence congestive heart failure patients become edematous and puffy. Why? Because in congestive heart failure, when the heart fails, diminishes blood flow to kidney, stimulates renin, stimulates angiotensin, stimulates aldosterone, that lead to sodium and water retention, and that lead to worsening of the edema. To treat that, we use spironolactone. Why? Because spironolactone, if you give, it will go to the mineralocorticoid receptor, aldosterone receptor. It prevents aldosterone from binding with the receptor, so that the sodium and water retention doesn't occur in the kidney, so that the congestive heart failure doesn't worsen. Hence we use spironolactone. But in the same patient, if you happen to use aspirin, aspirin antagonizes. That is, mineralocorticoid will tell, no, aldosterone you can't bind, because I am the mineralocorticoid receptor antagonist, I have come here, I will not let you bind. It will tell to aldosterone. But if aspirin is there, it will tell, hey, who are you to tell mineralocorticoid receptor like that? You can't tell, hey, mineralocorticoid, you come and bind, it will tell. Mineralocorticoid antagonist is spironolactone. Spironolactone's mineralocorticoid antagonistic effect is blocked by this fellow aspirin. Okay? Then if you give spironolactone, congestive heart failure patients, if they are already taking aspirin, the spironolactone's effect is no more working. That's what the point is all about. So doctor, let's go to the next. See, some concepts, what happens as we keep reading, at one point of time we digest it. First time it looks little slightly enigmatic. 2 minutes will be out of video, you will get that offline message, don't worry.